Awake fiberoptic intubation, a cornerstone technique in difficult airway management. When the airway is dangerous, you don't put the patient to sleep. You stay with them while you secure it. Awake fiberoptic intubation is not a backup plan. It is the gold standard when the airway is predicted to be difficult. Why? Because the patient is breathing. Because the airway reflexes are protecting them. Because if we fail, we can still wake up and try again. Use it when masses, swelling, trauma, radiation, limited mouth opening, cervical instability. Anytime, Plan A, asleep would be, Plan D, awake. Introduction. Awake fiberoptic intubation, AFOI. 1. Awake fiberoptic intubation, AFOI, equals intubation performed while the patient maintains spontaneous ventilation and protective airway reflexes. The patient stays awake, breathing and protecting themselves. AFOI is intubation done with spontaneous ventilation and active airway reflexes. 2. Gold standard technique for the anticipated difficult airway. The gold standard for the airway you expect to be difficult. When you anticipate trouble, this is how the experts do it. 3. Combines flexible fiber optic bronchoscope (FOB) guidance with adequate topical anesthesia plus or minus judicious sedation. See it, numb it, guide it. A flexible fiber optic bronchoscope for vision, plus excellent topical anesthesia plus careful light sedation. 4. Preserves airway patency and spontaneous respiration throughout the procedure, key safety advantage. The airway stays open. Breathing never stops. That is the safety. That is why we choose awake. Because the safest airway is still working while you secure it. Other names, synonyms. 1. Awake fiberoptic bronchoscope, FOB, guided intubation. 2. Flexible bronchoscopic intubation FBI. Awake technique. 3. Awake flexible fiberoptic intubation, AFFI. 4. Conscious, awake endoscopic intubation. 5. Fibreoptic assisted awake intubation, FAAI. 6. Awake look, technique. Used informally when the scope is used diagnostically before deciding on general anesthesia. Organizational definition. 1. Difficult Airway Society. DAS, AFOI is defined as the technique of choice for securing an anticipated difficult airway, using a flexible fiber optic scope to visualize and intubate the trachea in a spontaneously breathing, awake or lightly sedated patient. 2. American Society of Anesthesiologists, ASA, difficult airway algorithm, recommends awake intubation, including fiber optic, as the primary pathway when difficult airway is recognized before induction of anesthesia. 3. All India Difficult Airway Association, AIDAA, other national bodies, echo similar definitions, emphasizing preservation of spontaneous ventilation as the defining safety feature. 4. Core Organizational Consensus Definition, a technique for securing the airway with a tracheal tube, using a flexible bronchoscope for visual guidance, performed in a patient who remains conscious, cooperative, and breathing spontaneously throughout. History. 1854. Manuel Garcia, a singing teacher, first visualized his own larynx using mirrors, early foundation of laryngoscopy concepts. 1960s. Development of fiber optic technology, glass fiber bundles, by Hopkins and Company enabled flexible endoscopy. 1967. Peter Murphy first described using a fiber optic bronchoscope to intubate a patient with a difficult airway, considered the birth of fiber optic intubation. 1970s–1980s. Refinement of flexible fiber optic bronchoscopes for routine anesthetic use. Techniques for topical anesthesia and nerve blocks developed. 1990s. Formal incorporation of AFOI into difficult airway algorithms, ASA 1993 difficult airway algorithm. 2000s. DOS Guidelines, UK formalize awake fiber optic intubation pathways. 2011, NAP4 project reinforces importance of AFOI in preventing airway-related deaths and brain injury. Present day, integration with video-assisted fiber optic scopes, disposable scopes, and simulation-based training programs. Why? Awake. 1. Avoids induction of general anesthesia before airway is secured. Secure first. Sleep later. We do not induce general anesthesia before the airway is safe. 2. Maintains upper airway muscle tone, prevents collapse seen after GA induction. Keep the airway open. Muscle tone stays active. The airway does not collapse like it can after GA induction. 3. Preserves spontaneous ventilation as a safety net. Breathing is the safety net. Spontaneous ventilation continues throughout. If one step fails, the patient is still breathing. 4. Patient can cooperate, head positioning, swallowing, phonation cues. Use the patient as your partner. They can follow commands. Head position, swallowing, making sounds. These cues help you navigate. 5. Avoid, can't intubate, can't ventilate, CICV, scenario in a paralyzed patient. Avoid the worst case scenario. No, can't intubate, can't ventilate, in a paralyzed patient. Because with AFOI, you never create a problem you cannot fix. Indications. 1. Anticipated difficult airway on assessment. Malampathy 3 or IV, limited mouth opening, reduced neck mobility. 2. Morbid obesity with predicted difficult laryngoscopy. 3. Cervical spine instability or pathology. Trauma, rheumatoid arthritis, ankylosing spondylitis. 4. Upper airway tumors, abscesses, or masses distorting anatomy. 5. Airway trauma or burns. 6. History of previous difficult intubation. 7. Temporomandibular joint disease or limited mouth opening. 8. Congenital airway anomalies. Pierre Robin, Treacher Collins. 9. Obstructive sleep apnea with anticipated difficult mask ventilation. 10. Halo traction or unstable cervical spine fixation. Contraindications. Absolute. 1. Patient refusal. 2. Total upper airway obstruction. May worsen with topicalization or sedation. 3. Local anesthetic allergy to all classes. Relative. 1. Incooperative patient. Children, cognitive impairment, psychiatric conditions. 2. Active bleeding or copious secretions obscuring the fiber optic view. 3. Severe hypoxemia limiting time for the procedure. 4. Inability to tolerate topicalization. For example, severe coagulopathy for nerve blocks. Pre-procedure airway assessment. 1. History, previous anesthesia records, snoring, OSA, radiotherapy, airway surgery. Look for red flags in the patient's past, previous anesthesia records. History of snoring or obstructive sleep apnea, previous radiotherapy to the head and neck, any prior airway surgery. 2. Examination. Malampathy score, mouth opening, interincisor gap, thyromental and sternomental distance, neck mobility, extension. Dentition, micrognathia, retrognathia. The airway physically. Malampathy score. Mouth opening. Measure the interincisor gap, thyromental distance and sternomental distance. Neck mobility and ability to extend. Dentition status, micrognathia, and retrognathia. 3. Imaging. CT MRI neck if mass, trauma, or cervical spine pathology suspected. Order CT or MRI of the neck if you suspect a mass, trauma, or cervical spine pathology. 4. Nasendoscopy in clinic, if available, to assess nasal patency and supraglottic pathology. If available in clinic, use it to check nasal patency and look for supraglottic pathology. Patient preparation. 1. Explain procedure in detail. Informed consent. Address anxiety crucial for cooperation. Talk first. Fear kills cooperation. Explain the procedure in detail. Take informed consent. Address anxiety. Calm patient is a safe patient. 2. Fasting status confirmed. Aspiration risk. Confirm fasting. Empty stomach means lower aspiration risk. 3. Anesthesiology. Glycopyrrolate IV 20 to 30 minutes prior, dries secretions, improve ob view and topical anesthetic contact. Dry the airway. Give glycopyrrolate IV 20 to 30 minutes before. It dries secretions. Improves your fiber optic view. Helps topical anesthesia work better. 4. IV access secured. Secure IV line in place. 5. Standard monitors. SPO, ECG, NIBP, capnography if possible. Standard monitors. SPO2, ECG, NIBP. Add capnography if possible. Supplemental oxygen throughout nasal cannula, or via a dedicated port on the intubating attachment. Connect everything. Give oxygen. Always. Use nasal cannula or the oxygen port on the intubating attachment. Do not let saturation fall. 7. Difficult airway trolley and emergency equipment immediately available. Plan for the worst. Difficult airway trolley and emergency equipment must be in the room. Right now. Not later. 8. Skilled assistant present. Bring your team. A skilled assistant must be present. You do not do this alone. Equipment checklist for AFOI. 1. Flexible fiber optic bronchoscope. Adult and pediatric sizes plus light source. Your eyes in the airway. 2. Appropriately sized endotracheal tube. Have reinforced or specialized ETT ready. Her flex tip works well. 3. Airway topicalization devices. Magic atomizer, nebulizer, spray as you go epidural catheter. For anesthesia where you need it. 4. Local anesthetic agents. Lidocaine and other options for full airway anesthesia. 5. Oral or nasal intubating airways. Obicepian, Berman, Williams airway. To guide the scope and keep the tongue out of the way. 6. Bite block. Protect the scope and protect the patient. 7. Suction. Clear blood and secretions. A clean view is a safe intubation. 8. Oxygen delivery and insufflation device. Nasal cannula or oxygen port on the swivel adapter. Do not let them desaturate. 9. Video laryngoscope backup. Plan A may fail. Have Plan B in your hand. 10. Full difficult airway cart. Supraglottic airways, crocothyroidotomy kit, and all rescue equipment. Immediately available. Not in the storeroom. Routes. Nasal versus oral. Nasal route. 1. Often easier alignment with laryngeal axis. Better alignment. The scope follows the natural curve straight to the laryngeal axis. 2. Better tolerated awake. Less gag reflex stimulation. Better tolerated awake. Less gag reflex. Less stimulation. Patient cooperates more. 3. Requires vasoconstrictor, e.g., topical xylometazoline, phenylephrine plus lubricant. Prep is mandatory. Use vasoconstrictor first. Xylometazoline or phenylephrine. Add lubricant. Make the path smooth. 4. Risk of epistaxis. Know the risk. Epistaxis can happen. Be gentle. Be ready to suction. Oral route. 1. Requires an intubating oral airway, Obicepian, Berman, to guide scope in midline and protect against biting. Use a guide. Intubating oral airway required. Obicepian or Berman. Keeps scope midline and protects against biting. 2. Preferred if nasal contraindicated coagulopathy, basal skull fracture, nasal pathology. Choose it when nasal is not safe. Use oral if nasal is contraindicated. Coagulopathy, basal skull fracture, nasal pathology. Topical anesthesia. Principles. 1. Goal. Anesthetize the entire path. From nasal or oral cavity, to oropharynx, to hypopharynx, to larynx, to trachea. If one spot is missed, the patient will cough. Technique. Spray as you go. SAYGO through the working channel of the scope. See it, spray it, go deeper. Layer by layer. 3. Drug of choice. Lidocaine. Most widely used. Comes as 2%, 4%, or 10% spray. It is fast, effective, and predictable. 4. Safety. Know your dose. Maximum safe dose of lidocaine is 4.5 to 7 mg per kilogram. Track every mg you give. Watch for last. Low anesthetic systemic toxicity kills. Regional nerve blocks. Adjuncts for AFOI. 1. Glossopharyngeal nerve block. Covers the posterior tongue and oropharynx. Blunts the gag reflex. Makes scope passage smooth. 2. Superior laryngeal nerve block. Covers from the epiglottis down to the vocal cords. Stops pain and cough on touching the larynx. 3. Transtracheal block. Also called translaryngeal block. Inject through the cricothyroid membrane. Anesthetizes below the vocal cords. The cough it triggers helps spread anesthetic through the trachea. 4. Why use them? Blocks cut down your total topical lidocaine dose. They improve patient tolerance and cooperation. Know the risks. These are not free. Vessel puncture, hematoma, airway compromise if done poorly. Sedation strategy for AFOI. 1. Goal. Awake, calm, breathing. Give anxiolysis and comfort. Preserve spontaneous ventilation. Preserve airway reflexes. 2. Rule. Titrate to cooperation. Use minimal sedation only. Patient must stay rousable. Patient must stay cooperative. 3. Common agent. 1. Dexmedetomidine. The favorite. Provides sedation without significant respiratory depression. Gives some analgesia too. Agent 2. Fentanyl. Uses target-controlled infusion. Blunts airway reflexes and cough. Ultra-short half-life. Wears off fast. Agent 3. Midazolam. For anxiolysis and amnesia. Small titrated doses only. Do not knock them out. Or, common practice. Combine agents. Example. Dexmedetomidine plus remifentanil. Synergy gives comfort with less respiratory risk. 4. Red line. Avoid oversedation. Too much sedation causes airway obstruction. Too much is apnea. That defeats the entire purpose of the awake technique. Step-by-step procedure. Awake fiberoptic intubation. 1. Position the patient. Semi-recumbent or sitting is best. Use supine only if cervical spine precaution. 2. Apply monitors. Start supplemental oxygen. Do not let them saturate during the procedure. 3. Give anesthesiology. Dry the secretions. Skip this step only if already given. 4. Establish sedation. Titrate slowly and cautiously. Goal. Calm, cooperative, breathing. 5. Topicalize the airway. Do it progressively. Nasal or oral cavity to oropharynx to larynx to trachea. Anesthetize every level before you pass it. 6. Insert airway adjunct. Use intubating oral airway or nasal trumpet if needed. Keeps the path open and protects the scope. 7. Advance the scope. Go under direct vision. Stay midline at all times. 8. Identify landmarks. Find the epiglottis first. Then find the vocal cords. Then advance into the trachea. 9. Confirm tracheal position. Visualize tracheal rings. Visualize the carina. If you do not see rings, you are not in the trachea. 10. Railroad the ETT. Slide the preloaded tube over the scope into the trachea. Smooth, steady, no force. 11. Remove the scope. Withdraw the scope carefully. Confirm tube position. Check visually. Confirm with capnography. 2 methods. Every time. 12. Only then induce general anesthesia. If surgery requires G. Only after the airway is secured. Confirmation of correct placement. 1. Direct visualization. See tracheal rings through the scope. See the carina. If you see it, you are in the trachea. 2. End tidal CO capnography. Get a waveform after tube placement. Square wave means the tube is in the lungs. No wave means you are wrong. 3. Bilateral chest movement. Watch the chest rise. Listen with auscultation. Air should be in both lungs, not the stomach. 4. Fogging in the tube. It supports correct placement, but it is not definitive. Do not trust fog alone. Advantages of AFOI. 1. Maintains spontaneous ventilation. The patient breathes the whole time. This cuts the risk of a CICV scenario. Cannot intubate, cannot ventilate. 2. Allows continuous neurological assessment. Critical in unstable cervical spine cases. Patient stays awake. You can check them during the procedure. 3. No neck manipulation needed. Avoids extension and movement. Protects the spine while securing the airway. 4. High success rate in difficult airways. When done by trained hands. It is the gold standard for predicted difficult intubation. 5. Patient can talk to you. They can report pain. They can report dyspnea. They tell you immediately if something is wrong. Complications and risks of AFOI. 1. Local anesthetic systemic toxicity. Last. From giving too much lidocaine. Track your dose. Watch for seizures and arrhythmias. 2. Airway trauma. Includes epistaxis with the nasal route. Be gentle. Lubricate. Vasoconstrict first. 3. Laryngospasm and bronchospasm. From inadequate anesthesia or scope irritation. Topicalize well and go slow. 4. Aspiration. Airway reflexes are blunted by topicalization. Risk goes up. Have suction ready. 5. Hypoxemia. From a prolonged procedure. From over-sedation. Give oxygen and work efficiently. 6. Patient discomfort and anxiety. Can lead to procedure failure. May force you to convert an alternate technique. 7. Rare but serious. Vocal cord trauma. Mediastinal injury from transtracheal block. Know your anatomy. Respect the needle. Factors for success in AFOI. 1. Adequate patient counseling and cooperation. Explain what will happen. A calm patient who understands will help you succeed. 2. Skilled operator experienced with FOB. This is a hands-on technique. Practice makes it smooth, safe, and fast. 3. Thorough, systematic topicalization. Anesthetize every level. No gaps. No surprises. No coughing. 4. Appropriate, titrated sedation. Enough to relieve anxiety. Not enough to stop breathing. Keep them awake and cooperative. 5. Adequate anesthesiologic effect. Dry field equals clear vision. Secretions are the enemy of the fiberoptic view. 6. Backup plans readily available. Have video laryngoscopy ready. Have a surgical airway kit ready. Hope for AFOI. Prepare for everything else. AFOI in difficult airway algorithms. Recommended by major societies. ASA difficult airway algorithm supports it. DOS guidelines support it. It is first line for the anticipated difficult airway. Planned, not rescue. AFOI is before induction. Patient is awake, breathing, cooperative. Different from rescue techniques. Rescue techniques are for unanticipated difficult airway. Those happen after GA induction and failed ventilation. Patient education. Patients should be informed that 1. They will remain awake but comfortable during the procedure. You are not asleep. You will be calm and sedated. 2. Local anesthetic will numb the airway. This stops pain and the gag reflex. 3. Mild coughing or pressure may occur but is usually brief. It happens as the scope passes. It passes quickly. 4. They should avoid speaking and follow breathing instructions. Stay still. Breathe when we tell you. This keeps you safe. 5. Procedure enhances safety by maintaining natural breathing until the airway is secured. You breathe on your own the entire time. We only put you to sleep after the tube is in place. 6. Temporary sore throat or hoarseness may occur afterward. This is normal. Goes away in a few hours to a few days. Conclusion. 1. Awake Fibreoptic intubation remains the gold standard technique for securing an anticipated difficult airway. When you know it will be hard, this is the safest way. 2. It uniquely preserves spontaneous ventilation, thereby minimizing the risk of catastrophic airway loss. The patient breathes throughout. Cannot intubate, cannot ventilate becomes far less likely. 3. Success depends on a combination of patient preparation, effective topicalization or blocks, judicious sedation, and operator skill. Every piece matters. Get them all right and the airway is secured. 4. It continues to evolve with new technology and evidence-based protocols. Examples. Disposable scopes. Examples. HFNO. The technique is getting more accessible. 5. It should be a core competency for anesthesiologists, ICU physicians, and emergency airway managers. If you manage airways, you must know this skill. Take-home tips. 1. Think ahead. Identify the difficult airway before induction. Plan while the patient is still safe. 2. Topicalize thoroughly. Good airway anesthesia is the key to patient comfort and success. Numb it well or the patient will fight you. 3. Sedate sparingly. Maintain spontaneous ventilation. Maintain airway reflexes. Awake is safe. 4. Oxygenate continuously. Consider high-flow nasal oxygen when appropriate. Keep the saturations up during the procedure. 5. Communicate constantly. Reassure the patient. Coach the patient throughout the procedure. A calm patient makes your job easier. 6. Confirm with capnography. Continuous waveform capnography is the gold standard for confirming tracheal tube placement. See the wave. Trust the wave. 7. Always have Plan B, Plan C, and Plan D. Prepare alternative airway devices. Prepare emergency front of neck access equipment. Hope for AFOI. Be ready for anything. Professional quote. 1. The best difficult airway is the one anticipated, prepared for, and managed before it becomes an emergency. Plan early. Act early. Panic never. 2. Awake Fibreoptic intubation transforms airway management from a crisis into a controlled, deliberate, and life-saving procedure. You keep the patient breathing. You keep control. You save the day. Thank you for watching. If you liked this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.